To wrap up, Dr. Robert Weinreb from UCSD will present best approach to diagnosing glaucoma progression.
Great. Thanks, Lucy and Niels, for the invitation. They asked me to talk about the best approach to diagnose glaucoma progression. Number of disclosures. I'm not going to be talking about products, although I do receive research funding and research instruments from a number of companies in the diagnostic space. So, the glaucoma continuum. We can detect progression earlier than ever before. Is there a best approach for detecting glaucoma progression? And I'm sort of baffled by that because there are so many other considerations. And what I'd like to suggest is there is no best approach. Each of us finds an approach that we use in our clinical practice, and many of them are equally good. I'd like to present 5 take-home messages today. One of them relates to the visual field testing and OCT scans. And we've heard from a number of the speakers in these excellent lectures this morning that both of them are essential for detecting progression throughout the glaucoma continuum. It was also pointed out by a number of speakers that they might not agree with each other for a variety of reasons. A good baseline of reliable visual field tests is essential. You decide on the test pattern, you decide on your strategy, and you continue with them throughout the follow-up. Second point, both 24-2 and 10-2 should be assessed throughout the continuum. They offer advantages both in early disease and advanced disease. They're particularly useful. 10-2 is particularly useful early in disease if you think the patient has glaucoma, and the 24-2 is within normal limits. Medeiros and colleagues suggest that 2 reliable baseline tests followed by similar testing throughout the follow-up of the patient, maybe twice annually, are reasonable. There are a number of other approaches, including clustering at baseline and clustering at the end of follow-up, that have been suggested. In this excellent manuscript, they review some of the other recommendations that have been made and discuss why 2 baseline testing is probably sufficient with twice annual testing. Establishing the rate of progression is also important for individualizing treatment. Next, confirming visual field progression, absolutely critical. Not all patients who you think have glaucoma have glaucoma. Next, baseline optic disc photographs, I think, are essential in any patient with glaucoma. We heard from Dr. Greenfield about using photographs. I find them particularly useful for looking at disc hemorrhages and also for assessing parapapillary atrophy. Photographs are stable, instruments change, the software changes, but you'll always have a photograph of the patient. Structure function estimates of cup-disc ratio, I think, are not particularly useful. You have to correct for disc area, and there's really insufficient evidence that they're useful for monitoring change. And then finally, both disc and macula, OCT, scans should be obtained in all patients. Macula scans are particularly useful in advanced disease, as we heard from Dr. Greenfield. How can OCT progression be detected? Well, again, we're looking at the macula, both early in disease and also in patients in advanced disease. When we obtain OCT scans on our patients, we obtain both circumpapillary scans and we're obtaining macula scans. The average RNFL thickness is used by most to determine whether glaucoma is present and whether it's progressing. Alternatively, one can look at RNFL profiles and look for small changes. These might be more sensitive than averages. The guided progression analysis is useful for detecting change in disease. Topographic measurement of the rates of RNFL thinning with trend-based approaches are also useful. This is a beautiful series published by Christopher Leung from Hong Kong showing progression with OCT, looking also at TPA, GCP changes. Trend-based methods are typically more sensitive. Event-based changes are typically more specific. Change in already damaged areas is typically where change occurs. So you need to look at areas that are already damaged. And then finally, as mentioned by Angelo Tanna, there's some evidence now that OCT angiography, looking at vessel density measurements, might be changing earlier than some structural measurements. This is something that, of course, needs to be confirmed, but provides some very interesting information. To summarize, visual field testing and OCT scans are both needed throughout the continuum. Using both 24-2 and 10-2 should be routinely assessed. Confirming visual field progression, baseline optic disc photographs, and then using both OCT, circumpapillary, and macula scans. Thank you.